Hi, I'm Dr. Martin Rutherford. I am a chiropractor since 1979, and I am currently a certified functional medicine practitioner.
Dr. Randall Gates, I'm a board-certified chiropractic neurologist as well as being a chiropractor.
And last week we did weight loss, beyond the calories, part 3. And the reason I'm mentioning that is because part 3 was about hypothyroidism and weight loss and the complexities of that beyond simply taking a pill for your hypothyroid and losing weight, the complexities for most of you. This week we're going to kind of get a lot more into the thyroid itself. And the topic is going to be hypothyroidism. We're going to talk about depression and obesity. We're going to talk about its relationship to cardiovascular problems, particularly when your heart pounds too much. We're going to talk about how it's maybe related to your high cholesterol numbers, maybe not being able to carry a child to term, and also something called metabolic syndrome. So we are actually going to give a presentation on this, a live presentation Saturday at noon here at our office in Reno, Nevada. So this is going to be kind of a dry run. We've had a presentation that I've given several times. Dr. Gates and I are going to do this one together, and the reason that we're going through a dry run here is because there's so much new data out here on hypothyroidism, really kind of crystallizing a lot of the concepts that we knew were there based on what our patients and how our patients were responding or not responding to things that we did. And it was kind of nice to see that these are starting, that theories and understandings as to why the things we're going to be talking about are now in the literature. I believe you said that there's 50 articles.
Yeah, 50 references.
50 referenced articles attached to this presentation. For those of you who are more academically inclined or just interested to see if we're just blowing smoke here, there's plenty of stuff there. So we're gonna go through hypothyroidism. It has really become an unbelievably important subject to the degree where I know myself, I wrote an article on it not that long ago, and when my research, my research compared to his research is like just a little research, but in my research, it caught my eye on the Subclinical hypothyroid website that the Mayo Clinic had an article in there in its communique to the doctors all over the country who subscribe to their newsletter, if you will, that summarized itself by saying, we urgently, and I'm quoting as best I can, but this is pretty close to accurate, we urgently need a multi-facility, national, double-blind, government-funded study to determine how do we dose people who have subclinical hypothyroidism, meaning that the Mayo Clinic has come out and said, in essence, now I'm paraphrasing, not quoting, we really don't know what to do with these thyroids. I mean, that's really what it said. It was shocking to me because it was like 6 pages I read. And I'm going like, wow, this doesn't sound like very definite information. And then the last paragraph kind of all pulled it together. So it's a problem. And those of you who are out there having thyroid problems, if you're taking medication and it's not working, or you're taking medication and it's not working because you don't feel any better, or you have every symptom that there is of thyroid problems, but your blood tests are normal. And I can go into a couple of other scenarios. If you're driving your doctor crazy and they're trying to dose you up and down and sideways, and you're stressing your doctor out. If you walk into my office, our office here, and you talk to me and you go, I'm gonna be your worst nightmare because I'm driving my doctors crazy. You need to watch this for the next 30, 45 minutes, hour, whatever it takes. So hypothyroidism. Background. How about starting with your overview of hypothyroidism?
Okay. So basically with hypothyroidism, it's a very common condition, as Dr. Rutherford outlined. Estimates vary, but some say that the thyroid replacement medications are the 4th most commonly prescribed medications in this country. And with that being said, you would think if you just have a low thyroid, your thyroid's not producing thyroid hormone, you take the thyroid medication, you should be fine. and we shouldn't even be talking about this.
Right.
But the issue is that there is an abundance of the hypothyroid patient population out there who doesn't feel well. They're still depressed, they're still overweight, they still have cardiovascular disease and hyperlipidemia, which is elevated cholesterol and things like that. And they're talking to their doctor saying, hey, you know, I have XYZ symptom. And their doctors, in essence, are going off of what Dr. Rutherford alluded to with the Mayo Clinic guidelines, because there's still ambiguity in endocrinology, ambiguity coming from endocrinology to the general practitioners out there who you may be seeing for your thyroid, and how to manage this condition effectively enough for you not to have these symptoms. And what we're going to go through today is all the disparate pieces of hypothyroidism. It's more than just a low thyroid, to say the least.
Way more. Way more. In fact, we started getting into this when we were treating fibromyalgia. We started out, Dr. Gates is board certified functional neurologist, chiropractic neurologist, and their field has to do with the brain and the nervous system. So what the heck is he doing talking about this? You'll find out. And functional medicine is the field in which we look at the function of the body. We look at why that symptom is occurring. We're not too crazy about listening to what the name of the disease is. We want to know what is the chemical reaction, or what is the pathway that's not working, what's the feedback mechanism that's not working, and fix that, which can frequently be done with diet and cleanses and herbs and botanicals, but it's a very complex thing. So we've put the two of them together in our office, and interestingly enough, developed kind of a chronic pain practice, because the brain controls everything. Everything that I just got done talking about affects the brain. And in putting together a comprehensive approach, we started seeing that we were attracting chronic pain patients. We started out with fibromyalgia, and it was interesting to find out that virtually every fibromyalgia patient that has ever walked in this door has had a thyroid problem, and the vast majority of them had the thyroid problem called Hashimoto's. And that's when we started to realize, man, we got to start getting like conversant in this field of thyroid. So that's kind of how a brain doctor and a metabolic guy kind of, okay, we got to get into this.
I'm really glad you said it, because going back, that is how this evolved. You know, thyroid is incredibly important to migraine headaches. And the textbooks will say, once you make sure a migraine patient doesn't have a brain tumor, you got to make sure they don't have a thyroid problem. And lots of times the thyroid issue may be missed because they're not looking for Hashimoto's. We'll talk about all this.
My mentor, Dr. Datis Karazian, when I was struggling with this early on in my career, and he was always advising me, test the thyroid, test it. Why if somebody come in with peripheral neuropathy in their feet? I'm like, why am I testing your thyroid? And one day he finally said to me, if you don't test every chronic pain patient that comes in your office for thyroid, I'm not talking to you anymore. I was like, okay. And we started doing that, and the results were astonishing as to how many had thyroid problems. And it became obvious that it wasn't just a coincidence, that there was a direct relationship in some way, shape, or form to that person's chronic situation. So that's how we see thyroid. That's how important we see it.
And we can go on and on and on, but I want to stay on track. Yeah, I could go off on 6 tangents there.
Okay. So Hashimoto's.
Yes.
Hashimoto's, is that where you want to go next?
Yeah.
We're testing this out, guys, so you can give us plenty of feedback.
Well, and a big piece of this presentation is we have done disparate pieces of this presentation and different presentations, but we're trying to bring it together so it's kind of one final piece to hypothyroidism. So Hashimoto's disease is the eponym for when the immune system kills the thyroid. So the immune attack on the thyroid was discovered in 1912 by Dr. Hashimoto Hikaru out of Japan. And he described this immune response to the thyroid as causing enlargement of the thyroid. We now know that for all of you hypothyroid patients out there taking Synthroid or levothyroxine, that upwards of 90% of you have Hashimoto's thyroiditis, 90 to 95%. If you have subclinical hypothyroidism, which we'll talk about, upwards of at least 80% of you have Hashimoto's thyroiditis. And now there's this new entity where they're calling it seronegative Hashimoto's thyroiditis, which is where the immune system is attacking the thyroid, but we can't find any elevated immune counts to the thyroid. But if they do a biopsy of your thyroid, they can see it.
Okay.
So that's Hashimoto's thyroiditis.
Okay.
Now, going into the causes of Hashimoto's, this is important because, again, we're going back to you're taking a thyroid medication. If you're watching this video, you're probably still having symptoms of thyroid dysfunction. we look heavily at the causes of this immune response to the thyroid. The three simple ones are stress, viral infections in the thyroid gland itself, possibly initiating the immune system to kill the thyroid because it's trying to get to the virus, as well as food intolerances, such that certain foods seem to look like the thyroid. There's also talk in the literature about inflammation from the gut and the liver causing inflammation throughout the body, and the thyroid seems to be the most susceptible tissue in the body for an immune response to get overreactive to because of that systemic inflammation.
Yeah, I think the studies are even a couple years back. I think Dr. Krosnick was teaching that if you had celiac disease, which is an inflammatory autoimmune disease of the gut, you'd have like a 75% chance of having
Right.
an autoimmune attack on your thyroid, this Hashimoto's, and apparently it's more than that.
Yeah. And the reference article we cited was 47% of those with gluten antibodies have thyroid antibodies.
And these are crazy numbers that we're talking about, okay? When we're talking about maybe 90, what we're saying in essence is that probably 90 or 95% of you out there who have been diagnosed with hypothyroidism probably have Hashimotos thyroiditis. Mm-hmm. And the causes of it being stress, virus, food
intolerances, gut inflammation.
So this is an entirely different world and an entirely different paradigm than is being presented out there over in. And again, I always hate to use this, say, in the medical model, because we're not cutting the medical model, okay? I have Hashimoto's, I have celiac. I looked for methods that could help me. These are the methods that ultimately helped me. So I don't axe to grind with medicine, okay? But medicine's a big boat. Medicine is a big ship, and it's hard to turn that ship around and change what you're doing. There's a lot of things that have to happen before they can come to embrace a lot of the types of things we're going to talk about today. Studies have to be done, articles have to be written, because in the end, they're going to probably try to use a medicine, and it takes like 10 or 15 years to get a new medicine online. And whereas we've been able to, we now being our entire group of functional doctors have been able to kind of evaluate this, because pretty much what we do is going to work or it's not going to work, but it's not going to make anybody better. We're talking diet, we're talking stress management, we're talking.
You're not going to make anybody worse, typically. Yeah.
Right.
Yeah, exactly.
Right. So, okay, so hypothyroidism, components of the thyroid disease, you're already kind of going through that.
Mm-hmm. Well, let's talk about subclinical hypothyroidism.
Okay.
Are we to that point now? I have this flow. Okay. So going with this, so as we've talked about in other broadcasts, many of you will go to your doctor and your doctor will say, oh, your thyroid's kind of borderline. Oh, your thyroid's normal. And then you'll bring your lab tests into us and we'll be looking at it and say, actually, your lab tests are not normal. So you may be a little confused there. And really where that comes from is this entity called subclinical hypothyroidism. And that's what a lot of the Mayo Clinic communique was about. So let's go through a little thyroid physiology. So the brain sends a chemical to the thyroid, telling the thyroid to work. It's called thyroid stimulating hormone. The thyroid makes inactive thyroid hormone called T4 that circulates throughout the body and primarily gets converted to active thyroid hormone called T3 in your gastrointestinal tract in your liver. Now, relative to frank hypothyroidism, they'll say it's a TSH, which is the hormone from the brain to the thyroid, over 8 or 10. And that's really a severe case of hypothyroidism in our opinion. And anything less than a TSH of, let's say, 8, they don't really consider it to be that significant until they started talking about subclinical hypothyroidism. And now the data is starting to become overwhelming regarding subclinical hypothyroidism and its effects on miscarriage, depression, metabolic syndrome, a variety of health conditions. And so with that, the local hospital here, they changed their TSH value from, I think it was 0.5 to 5.5 down to 3.7. And there are research articles now saying that anything over 2.5 is too high, especially for a pregnant female. And we've been talking about that for years.
Well, the significance of this is we've been having doctors tell people, of course, they go to them, they're frustrated, they come to us, they're getting, but that we tell them that the numbers are different. And of course, we've taken a lot of criticism, a lot of heat. We being our colleagues also taking a lot of heat, and it was a little hairy, frankly, because you're sitting here with a patient in front of you who wants to get better, you know that this is what you've seen in clinical practice, and you make the decisions based on that. And for a long time, a lot of people were taking a little bit of a risk to kind of go against the standard embraced numbers there. But now what Doug Gates is saying is those numbers are coming down substantially from what they used to be. And now I think doctors are going to be getting a much, much better idea of at least who's still sick in front of them. Whereas before they'd say, oh, your numbers are normal. Now it's like, now they might be saying, well, okay, you're not, we still need to play with your medication a little bit. And we'll get into that in a few seconds. So the mantra of, well, I know my lab tests are normal, but I still might have it. People are actually starting to come into our office now saying that,
yeah, exactly.
Which 5 years ago, they would come in our office and say, well, how come my medical doctor says this and you say that, and so on and so forth. So this was a big, to have our local hospital, which basically dominates the entire Northern Nevada, to start changing all of their numbers. We can talk about the TPO numbers later, which are shocking to me to see it, to what we've been saying for years. It's not just gratifying, it just takes a lot of pressure off. When you're saying, hey, no, this is wrong. I know that they're saying you're normal, but here's the range. You're out of that range. You have this problem. So that's kind of a general overview. Hypothyroidism as it's treated today is basically medication.
Basically, it's levothyroxine or Synthroid. That's basically what you're going to get out there. Your doctor may use Armour Thyroid, which is more a natural alternative. It does have some T3, the active thyroid hormone, in it. But in essence, that's usually how it's managed from a general hypothyroid standpoint.
Yeah, and as you're going to find out, it is infinitely more complex than that. And it makes sense because the thyroid is just so integrated into every single cell of your body. I mean, when it goes down, everything goes down. But you can't make red blood cells. I mean, most of you have been having your gallbladders taken out. A lot of them, it might be because your thyroid is slowed down and your gallbladder is slowed down. It's like one of the number one causes of constipation. Most of us know, well, it's weight, my hair is thinning and weight loss, but it slows everything down. It has receptor sites in virtually every cell in your body, so it is a big deal. So it makes more sense. Now, nobody ever asks why. Why is the thyroid?
Right.
Why is the thyroid hypo?
Exactly.
Why is that? Well, your number is this. We'll give you that. You're standing there and saying, Doc, I got all these symptoms, and the doc's like, but your numbers are good, dear. So it's nice. It's nice, and I know that you're still feeling it's good, but the numbers are good. We'll check you back in 6 months.
And you probably want to go home and exercise. That's what our patients call it.
Yeah, go home and exercise and not get any type of response. So I'm leading next to the indication to the fact that we discussed this beforehand. There is essentially, I don't think it would be out of line to call it an epidemic of thyroid problems. And I think part of what makes it an epidemic is I think they're not being treated. I think if you looked at the number of thyroid people that are being treated in the country, you said fourth most common prescribed medication in the country. I don't think anybody denies that there is a lot of thyroid patients out there. But when I say the term epidemic, I mean these are thyroid patients who are not getting correctly treated, and this epidemic is leading into all of these things that we talked about.
Exactly.
Things that I just thought, this is a stunning thing to me in the healthcare field, in the healthcare model, that this is not understood. And we see it every day. And so we talk about thyroid with some confidence because we're using the things that we're about to talk about in our approach to the patients. And so why is it that, I think we kind of talk about why is it there's an epidemic of patients that don't feel well with medication, but we probably want to get into it more specifically.
Exactly. And let's first get into Hashimoto's. Is that in line with your?
Hashimoto's is perfect.
Okay, perfect. And so with Hashimotos Thyroiditis, the new research articles, I mean, you can check them out on our website. They're like 2015, late 2014, are discussing, well, Hashimoto's is this, the most common autoimmune disease in America. And it's becoming even more prevalent and we don't know why we don't have a good medication for it yet. I mean, that's really what they're saying. But in essence, it's all the reasons that we've talked about. And so with Hashimoto's, there's a viral component, there's a food component or gut-related component, and a stress component. And these factors seem to be merging in our population. The reason why I bring this up again is that this is a huge emphasis for us. When we were 4 years ago treating fibromyalgia patients, scratching our head, trying to figure out how we're going to help their thyroid condition to help their pain, we, as if you want to term us more on the natural side of things, we were trying to affect the thyroid without medications. And that can be done to a certain degree, we have found in certain cases. So we have a gut-centered approach. So as Dr. Rutherford alluded to, a lot of patients with Hashimoto's thyroiditis can have antibodies to gluten. So we started eliminating gluten. Then we found that there were other
connection
foods.
there being gluten can damage your gut,
Right.
and thus the gut connection with the thyroid.
And then the immune system can attack the gluten.
Hashimoto's and celiac.
And the gluten molecule can look like the thyroid molecule. That's the current thinking. And then we're finding that other foods seem to do the same thing. Now, we started changing our diet in accordance with that. Then we started seeing the literature on viral infections in the thyroid. So we would attack the gut, and if we didn't see a change in how the thyroid was functioning symptomatically and objectively through lab testing, we would refer patients either for a natural antiviral approach, and if that didn't work, we'd refer them to their medical doctor for a medical antiviral approach. And then we started seeing some astounding changes.
And did we make it clear that all these are working because Hashimoto's is an immune attack on the thyroid, and that all of these are exacerbating the immune system, and then that's attacking your thyroid?
I think I set it up earlier, but maybe it's good to accentuate that.
I think we talked about it with antibodies, but,
Right.
but a lot of people.
But in essence, Hashimoto's is an autoimmune disease. So it's not as much a thyroid problem, it's an autoimmune disease.
Exactly.
So with the autoimmune disease, that's where we started getting focused on the gut. And then we started getting focused on the viral aspect, because if we could possibly calm down the viral infection in the thyroid, would the thyroid function better? Because we calm down the immune system. And then also stress. We evaluate stress significantly with our patients. We run detailed testing of the stress response, and we put patients through a number of procedures to bring down their systemic stress response.
And one of the things that I find, I do all the intakes in here, and I do the consults now and try to determine who's a good candidate, who may not be a good candidate for our clinic. And when you say stress, a lot of people think, well, I'm not stressed. I'm not stressed. So this is kind of a automatic stress. This is like a fight flight syndrome-ish type of thing. It's something that's going on and on and on and on. It frequently seems like there's a history of verbal abuse or physical abuse or sexual abuse or some sort of just huge, maybe they've had the pain for a long time they feel for, or maybe they walked into, maybe their husband died with short notice or something like that. And then this mechanism engages and it keeps going. It starts with bad chemistry in the body.
Exactly, because the stress response imbalances the immune system. That's basically how it works.
Right.
So we have those factors that we address. And in addressing that, we have observed that in certain cases, we can get to the cause of the Hashimoto's thyroiditis. Now, that's really big because that can affect dramatically how a person is feeling in our experience. And just know that Hashimoto's thyroiditis can present with normal thyroid hormones too. It's called Hashimoto's euthyroid. And even Hashimoto's euthyroiditis is associated with things like weight gain. It's associated with depression and miscarriages, independent of even thyroid hormones. So that's a demonstration of the power of the autoimmune response in the body to destabilize human physiology. And that is a huge component possibly of what's being missed by just giving you levothyroxine or Synthroid when there's all this other stuff going on in the background. Right. Causing these.
In other words, if their doc tells them, hey, all your lab tests are normal, you couldn't have that, you could have that.
Yes, exactly. And that's no criticism against your doctor again.
In fact, we're going to get into, even if the test specific for Hashimoto's is normal, you can have that. And these are important things you have to understand as a clinician if you're going to want to try to actually help that patient, as opposed to, and this might be a teeny bit of criticism, as opposed to doing doctoring by the numbers. I've often criticized, I'm a chiropractor for 79 years, and this is like 95% of my practice now. But I mean, I would always criticize people, as you well know, of doing spinal treatment by the X-ray, by the MRI. And I'm sure many of you out there have experienced having somebody show you something on the x-ray and say, this is here, we're going to do surgery and it's going to get better, and it doesn't. This is the same thing. This is the same thing. This is, okay, I looked at your numbers. I know you got every single symptom that there is, but Ms. Jones, I'll see you in 6 months. Just keep taking that. Just keep taking that levothyroxine, which I communicate basically. Pretty much that doesn't work, the Mayo Clinic communicate. So if we're like shaking anybody's world here right now, this is the stuff that we see every day. These are the things that you have to know and be aware of to even begin to hope to help a thyroid patient to overcome the problem that they have. So Hashimoto's thyroiditis, and you already talked a little bit about, did you want to re-talk about these other ones in a more focused fashion? Mm-hmm. Yeah, subclinical hypothyroidism?
Yes.
Most people probably never heard that term before.
Okay, so subclinical hypothyroidism, it's just an eponym, or it's not an eponym, but it's just a term that is basically saying what we thought was borderline normal is now actually a problem. And so again, going back to our TSH example, when TSH is above 8 or 11, most medical doctors will consider that to be an issue that requires thyroid medication. Below 8 or 11, it's kind of a gray area. And that's what the Mayo Clinic is talking about. However, the current literature is starting to shift with new studies that are demonstrating that if your TSH is above even 2.5.
For years, we've used 2.8.
Yeah, right. If it's above 2.5 or 3.7, if it's above that, that indicates that there is a thyroid issue, and the person may respond to thyroid medication relative to things like depression, things like cardiovascular disease, things like miscarriages, and we're going to talk about obesity too. Yeah. It's a little different, but we'll talk about it.
That is a drastic change in evaluative numbers.
Exactly, and that's one of the main reasons why you're watching this broadcast, because many of you out there have been told your thyroid is normal, but you're suspicious that you have a thyroid issue, or you're taking 25 micrograms of levothyroxine and you're still not feeling better. And it's because you're in this gray area, and your doctor, you have to understand, is handcuffed too. So if he were to load you up on thyroid medication until you felt better, if you had an adverse side effect from that treatment, you could sue him and win, and probably win big money.
Yeah. And even though maybe 1 out of 100 or 1 out of 1,000 would have that adverse reaction, even though all of his other patients were getting better, he would still be held accountable, because that wasn't, and still technically isn't,
the standard
of care right at this point in time.
Right. So that's why you out there are suffering with a thyroid issue. And I just want to jump on one thing. So they're saying that like 15% of the population has Hashimoto's. That's the upward estimate.
15?
15. But that is for an immune count over 100. As Dr. Rutherford alluded to, the current hospital here in our area, they say anything over 9 is too high. So 15% of the population, female population, has it over 100. Can you imagine what percentage of the population has it over 9?
Well, it's enormous.
It's staggering, and we see it all the time. Yeah. But anyways, that's a tangent. So going back to subclinical hypothyroidism, that's the main reason why you're watching this video. That's the main reason why a lot of you out there are suffering. And we also, the impetus for doing this is that so many of you are struggling with weight issues, and it breaks our heart because we know that you're exercising, you're eating right, you're eating in moderation, and your husband is still judging you because you can't lose the pounds. And you have to know that it's really not your fault. And until this whole issue is fully evaluated, many times we find our patients don't have a chance of losing weight until all these disparate pieces are taken care of.
Okay. So subclinical hypothyroidism, you go to the doctor, your numbers are a little bit off. Mm-hmm. TSH is a little bit off. The other numbers are pretty much normal and not enough to be treated because it's not over 10.
Right.
Okay. So that's a huge part of people coming here. Hashimoto's, we're going over like 4 categories here. Hashimoto's, it's not technically it's not a thyroid problem. It is your immune system attacking your thyroid, and you have to figure out the things that are screwing up your immune system. And Dr. Gates has indicated it's stress, virus, food sensitivities. And I will tell you right now, you have to figure out every single food sensitivity, because if you miss one, it will sabotage it. And then possibly inflammation again from that gut, which is kind of one and the same with food sensitivities, but that's a whole nother topic. So thyroid conversion is kind of an interesting one. It's the one that we kind of started out with, is thinking had a huge amount of weight. And it is involved.
Mhm.
Not as involved as the autoimmune attack and
Right.
so on and so forth, but it definitely, and you mentioned it, you kind of set the tone for it a little bit in talking about how the thing that thyroid conversion, it means that you make a hormone in your thyroid and it has to convert somewhere into active form, because the hormone that you make in your thyroid doesn't do anything until it's chemically converted somewhere else. And those somewhere else's are essentially, it's the liver. I mean, some of it is like in the muscle and some of it's stuff like that. But essentially, it's the liver. Essentially, like 60%, I think they estimate, is converted in the liver. So if you have a bad liver, I mean, now that's another thing we'll get into.
Yes, sir.
Yeah, but liver, you can have a bad liver, but talk about numbers. Talk about numbers. You can have a bad liver, but you don't have to be an alcoholic, or you don't have to have cirrhosis or anything like that for you to have a bad liver. I'm sure Dr. Gates will get into that. And then your gut is the second part, gut being small intestines, right? Mm-hmm. So small intestines is about 20% of where it converts. And then it converts. So remember I said your thyroid has receptor sites in virtually every cell in your body. What that means is the active hormone ultimately has to hook into that area of the cell, an area of cell called the receptor site, and it has to go through this reaction that makes it active, and it makes the cell create energy, and so on and so forth. So there are things that can sabotage whether that inactive hormone gets to the liver, or gets to the intestine, or gets to the cells, or there are things in the liver and the gut and the cell itself that could affect it. So and it's a part of what we're seeing. Mm-hmm. And Doug Gates is the daily clinician here now. For the last 3 years, he has been doing all treatment. So I'm going to defer to him on the actual clinical applications of this and how it maybe dovetails with Hashimoto's and so on. So.
Because so much of what we do is a gut-centered approach. We've talked about in other broadcasts. We find that if we start with the gut and the liver, that lots of times physiology will spiral back into control, so to speak, by fixing those entities, because everything goes out from here. And so we will retest our patients to see if they convert their thyroid hormones better after we fix their gut and fix their liver. And sometimes it happens, and sometimes it doesn't. If it doesn't happen and you're still tired, fatigued, depressed, then we're going to look at either referring you back to your doctor or a doctor we work with for evaluation of the active thyroid hormone approach. Because some of you have genetic issues to where you just can't convert that inactive thyroid hormone to active. Sometimes there are inflammatory components that won't allow that conversion to take place. And that it's just pivotal.
Sometimes there's medications.
Pivotal, yeah. And there are medications that can help with this too, or hinder this. So where I want to go with that is that you've all heard about T3, I'm sure. T4 versus T3. There's stuff on T3 out there now. And going back to 2003 Journal of the American Medical Association, they came out and said they took 46 people and they gave them T4, which is levothyroxine or Synthroid.
Which is the inactive form.
Right. And then they gave them a little bit of T3 and they saw no difference.
Which is the active form.
And so they said this T4, T3 thing is just a bunch of hooey and it's not effective. However, the literature is coming out now with studies where they're just using T3.
So their theory was that you were going to jam them with T4,
right,
and it was going to be converted into T3.
Right, and they knew that wasn't happening.
Not working.
They knew that wasn't happening, but then they said, well, let's give them a little T3 because some alternative nut jobs are doing this, and let's see if it actually works. And it didn't. But the current literature is coming out with studies on just using T3 being significantly more effective for the hypothyroid patient to be able to lose weight, significantly more effective for things like depression. And so, however, we all have a way of thinking. It's called a paradigm. And the paradigm in endocrinology is still T4, whereas the paradigm in integrated medicine, if you want to term it that way, is shifting more to T3. Now, this is just, again, one small snippet. This is still not addressing Hashimoto's. It's not addressing the viral gut, inflammatory, stress-based components to that. It's still not even, subclinical hypothyroidism is different from this as well. So this is just another piece that has to be evaluated for you as the thyroid patient who's suffering out there still with your lingering symptoms.
Yeah, so given the complexity of the thyroid's effect on all of the cells in the entire body and all the systems in your body, it's not surprising that it's a little bit more complex than giving a person inactive T4, which things are always seen like duh after you look backwards on things, but you're getting the complexity of it now. You're getting the understanding of how this needs to be worked out and how it just isn't a paradigm that responds to levothyroxine or
Synthroid.
Thank you, man. My brain just went there. See, my brain goes through, or Synthroid. And one more category, hypothyroidism and metabolic syndrome.
Mm-hmm.
And these things, I can't even tell you, I don't want to, I mean, I try not to be prone to hyperbole, but these things are huge. I mean, because who doesn't have, there's so many people out there with metabolic syndrome.
One-third of the
not even considered in why they're medicated, why the medication isn't working for that thyroid patient.
Exactly. One-third of the one-third of the population of America is overweight. Another one-third is obese. Estimates are varying, but some state that by 2050, 2/3 of us will be obese. That's an issue because obesity predisposes us hugely to cardiovascular disease, cancer, stroke, the major killers that we have in our society. Yet this whole issue seems to still be just pushed off to the side. And you're told to eat in moderation. That's my soapbox. But this is important because metabolic syndrome patients are found commonly to have subclinical hypothyroidism. And if you treat the hypothyroidism, it helps them to better regulate their metabolic syndrome. You're probably saying, what is metabolic syndrome? Metabolic syndrome is basically when somebody's overweight, they have a big waistline, they have high blood pressure, they have high cholesterol, and they may have some signs of prediabetes, which most of you out there may be saying, well, that's not me, but it probably is you, frankly, because a significant percentage of the patient population in America has high cholesterol, high blood pressure, which are medications above levothyroxine on the list of, the top 10.
And the reason you may not realize you might have gone, I know I'm gonna be doing a presentation or whatever you want to call it, a consultation with a long-term patient of mine who I was treating a couple weeks ago, and he said, I just want to get a workup. Okay, would you mind if I just did your blood test? And this is separate from our chronic pain group. And I know he's going to be very shocked to find out that he hikes. He looks like he's in really good shape, and he is in really good shape. But he's got metabolic syndrome. He's got insulin resistance, high cholesterol. He's got the whole thing going. Yeah. And he's going to be shocked to find out that he has it. So again, we have this picture of this person who's kind of obese and they have high blood pressure, although that's not a parameter particularly, but they have all of these different things, and that's who we have to picture. We don't picture the person who's just got this little tire developing here and maybe hikes all the time and so on and so forth. So it's, if you don't understand that the parameters that we've been looking at for sick people are the parameters that need to be, that are even there. If you don't understand that they're there and you can't look at them, it's hard to help people. These are the things that have led us to have 125 million chronic pain patients in this country. And you can check Dr. Gates's attachments to this, to the attachments from the studies to see how well supported what we're saying at this point in time is, but it has not been supported up until very recently, right? Very recently. And that's a good thing for us because we get beat up a lot over these things, but we'll get beat up less and less. So thyroid disease and the specifics. Now we kind of titled this hypothyroidism and how it affects miscarriages and depression, obesity. How individually do you want to go through this?
So let's start with miscarriage.
Okay.
I don't know if there's a more emotional and sensitive issue out there than this for two young people trying to start a family. And with miscarriages, they can be common. Things like polycystic ovarian syndrome can be associated with that. Polycystic ovarian syndrome is where you get cysts on your ovaries. A woman tends to have too much testosterone, tends to be a little overweight, but more specifically tends to have abnormal menstrual cycle lengths and tends to have too much testosterone, which can manifest as like facial hair growth and things of that nature. However, hypothyroidism subclinical hypothyroidism, and Hashimoto's thyroiditis are all independent risk factors for causing miscarriages.
Right.
And so even if you have elevated thyroid antibodies and normal thyroid hormones, that's still an issue. And they're talking about the literature that even those patients need to be treated with thyroid medication in order to protect the fetus. And it goes back to, again, when I was citing a TSH over 2.5 being an issue, that's where it was coming from relative to this pregnant female trying to have a baby and carrying it full term. We need to rescale our thyroid parameters. That's what they're discussing. But also subclinical hypothyroidism, that ties in. And if you're a pregnant female, just know you need your thyroid to be acutely looked at in order to ensure that you have the greatest probability of having a good pregnancy. Also, you have to keep in mind that if you didn't have Hashimoto's before you got pregnant and you are genetically predisposed, you can develop Hashimoto's very easily during the first 12 weeks of your pregnancy. Reason being hormone shift, as well as things like cortisol shift. And they're talking about that being pivotal in the process of Hashimoto's developing in a female patient during that time. Also know Hashimoto's can develop later on after you have the baby because your immune system shifts back again in order not to attack the fetus. And it goes back to more of its resting state. And in that process, it can start to attack you as well. So that's what we'd say relative to miscarriage. In essence, subclinical hypothyroidism, where they're saying that we need to treat it, miscarriage in pregnant females is one of the hottest areas. And it's now becoming definitive that this patient population needs treatment, minus what the Mayo Clinic said in their communique.
And let's go back to the fact that thyroid's involved in all of this. The Mayo Clinic saying
we need to wait.
We need to wait until we have a 10 or 15 year double-blind clinical study, government funded, so on and so forth.
And hopefully you can see this is more complex than just this pill versus that pill.
Yeah.
This is so complex, and that is why I was talking to a patient last night. Literally, her TSH has dropped from being elevated pathologically to in the normal range with a gut-based approach. We haven't done anything with the virus. We haven't done anything with stress. We've just done a gut-based approach.
So it can be a gut. It can be a virus. That's unusual in our experience to have just the gut alone.
Right.
Resynchronize the numbers. Usually it's a combination of these things that Dr. Gates is talking about.
But in doing that, then she was talking to her endocrinologist, and I have great respect for this endocrinologist, for the record. He's very well liked. He's a good man. And but he said, well, we haven't done a double-blind, placebo-controlled, randomized clinical trial on looking at the effects of foods, or this specific food we were talking about, on hypothyroidism. And I discussed with her, I said, you can see how complex just the stuff that we did with her gut was to get her fixed. And you can't create a research trial to control for all those variables at once.
You need to understand, that, and I'm going to try and be as polite as I can here, when someone doesn't know, that's their default.
Exactly.
That's their fallback. There hasn't been a study done on it. It's not in the studies. It's not in the studies.
Right. And lots of times there are studies. You also need to know that. Those 50 articles we presented, there are studies. The literature is mounting. However, they have to have their 10,000 patient sample size that they followed for 10 years to finally see something statistically significant in their eyes. Meanwhile, you're out there suffering. You're overweight. You're depressed. You may not be carrying a child full term. You're developing cardiovascular disease. But we're waiting on the studies. Do you see the difference there? Yeah. And so that is where, when we have patients coming to us who have these issues that need really a solution now, which may be in the next 6 months, this is what we have pulled together based on the current literature to create in our opinion, the most effective treatment plan integrated for you as the patient.
Right. So depression. I think people come in who have thyroid problems, they kind of get that thyroid can cause depression. Mm-hmm. They seem to get that thyroid and hormones can cause depression. That seems to be understood. We don't look at depression here as a mental problem or a social problem or a personality disorder. We do look at it as largely either a neurological issue, that would be frontal lobe, and or a metabolic issue, imbalances in certain chemical pathways in the body. Depression certainly is thyroid related.
Absolutely. So Hashimoto's thyroiditis has been talked about for a long time as being a cause of depression. Again, how many of you have even been tested for that? And how many of you have had a treatment that would have been different than just a thyroid medication for that? So you have to calm down the immune inflammation as much as is possible, because that immune inflammation goes into the brain and it doesn't allow those frontal lobe neurons that make us feel good to function as well. And it's so analogous to when we get sick. When we get sick with a cold or a flu, we feel depressed. The reason why is that you have a lot of inflammation in your body, and that inflammation goes to your brain. For a Hashimoto's patient, that is happening all the time, in essence. So that is why Hashimoto's predisposes to depression. The literature is now overwhelming too, in that subclinical hypothyroidism is associated with depression, and it needs to be treated, because when thyroid hormones are low, as Dr. Rutherford said, everything slows down. Every cell in your body slows down, including the brain cells associated with positive mental affect. And then there are studies now talking about T3 in depression. So there's studies saying, a lot of these patients who are taking thyroid hormone, they're not metabolizing it well in their brain, especially the elderly. And so they do better with T3 for their depression than T4. And T3 only. We're not talking T4, T3 combo, T3 only in these research articles.
And obesity is another one that people seem to understand that their thyroid has something to do with, but then the mass confusion, of course, is, but I'm taking my thyroid and my hair's still falling out and I still am overweight and I'm running 10 miles a day and I'm eating 1,800 calories and what's going on here?
Exactly. And so there, in the research articles, they'll say, these thyroid patients, lots of times, they'll feel a little better when we put them on levothyroxine, but they're still overweight and they don't seem to lose any weight or that much weight. And the weight they do lose is fluid, not fat loss. Very interesting. And so, because we have observed that to be true as well. So relative to thyroid and obesity, we have to go back to metabolic syndrome. So metabolic syndrome is that condition we talked about where people tend to get a little bit bigger of a waistline. They tend to have high cholesterol, high blood pressure, and signs of prediabetes, basically. There are different criteria for it, but that's the basic overview on it. And with that, there is this component of insulin resistance. Insulin resistance causes us to gain weight. If you eat a donut, we should make a certain amount of insulin to get the sugar from that donut back into the cells of our body. So I'll draw a little graph here. It should do this. However, people who have metabolic syndrome tend to make more insulin when they eat that donut. And that insulin causes us to gain tissue. What we're finding is that when someone has subclinical hypothyroidism, it actually makes the metabolic syndrome worse. It actually makes the liver function worse. And the liver is critical in processing of insulin. And so that is why your thyroid has to be appropriately managed for things like metabolic syndrome to be appropriately managed and to facilitate weight loss. Also,
if you're coming in here and you're been diagnosed with diabetes type 2, which he's not talking about, or metabolic syndrome, and you're taking medications and they're not, and you're taking 1 or 2 or 3 and they're not working, or if you're taking 3 and it's working, that's not working. No, you shouldn't need 3 or 2. Or frankly, even 1. If you're experiencing that, this is what's happening. This is what's happening.
Exactly. And then there are research articles coming out now comparing levothyroxine to liothyronine for thyroid patients who can't lose weight. And the results were definitive in that the patients who are taking liothyronine, which is T3, they lost a significant amount more than those taking levothyroxine. However, nothing seems to be changing in the way you as the thyroid patient is being managed, which is again a manifestation of your doctor being scared because they don't have this major 10,000 patient study to cite in case they started using something like a T3 based derivative. And the fact that even subclinical hypothyroidism is still an area that is gray for them. So that's why you're not getting these treatments, even though the information is out there. And one of the key things we want to do with you is give you the current information so you know.
It's massively out there. It used to be just a little trickle. Now there's so much out there. I mean, if you look at all of our hangouts, there's 20, 25, 50 today articles supporting everything that we're saying. Another thing that I see regularly And I hear regulars say, well, I came in here, I got a thyroid problem. Their patient may be here for weight loss, they may be here for fibromyalgia, they may be here for peripheral neuropathy, restless leg syndrome, whatever they're in here for. And their thyroid, they're not connecting their thyroid. I'll start asking questions about the thyroid. Their numbers are normal, they're vague. Do you know if it's helping you or not? No, I don't know if it's helping me. I take it, I don't take it, I don't feel any different. And I'll ask people, say, do you ever get heart palpitations? And they'll go, yeah, well, not all the time, but yeah. Or they'll say, the other extreme, yeah, I had to have an ablation or something like that. But they really don't know why I was having these, they're called arrhythmias, when your heart's really pounding. And so I think that's important. I think it is hugely important to cover in this.
Absolutely. So yeah, arrhythmias, cardiovascular mortality, cardiovascular disease is one of the areas where subclinical hypothyroidism correlates the most as being an issue is cardiovascular issues. So if you are a loved one, you don't want them to die of a heart attack, you need to have the thyroid really examined. And because if your thyroid hormone levels are appropriate, the heart functions better. And by appropriate, I mean it has to be in that narrow range of your TSH being like 0.37 to 2.5 or 3.7. And then with arrhythmias, as Dr. Rutherford is alluding to, arrhythmias are highly influenced by changes in thyroid function, either high or low. And so your thyroid has to be acutely managed if you have any form of heart arrhythmia, whether it's a ventricular arrhythmia, atrial arrhythmia, because if your thyroid is not appropriately managed, you are increasing your risk of having an issue that you don't want to have.
Yeah. And, dovetail with the next kind of subject is cholesterol is related to hyperlipidemia. Right. Increased amount of cholesterol is related to abnormal thyroid function. And now that's being accepted more and more. I see more and more. I hear more and more doctors telling people their high cholesterol might be related to their thyroid. It goes a little bit further than that, but obviously, if you have arrhythmias and high cholesterol, it's not good for your heart. It's not good for your heart.
Mm-hmm. And triglycerides. They're now using thyroid medications with triglyceride medications. Triglycerides are another form of fat, aside from cholesterol. They're using thyroid medication with these anti-triglyceride medications and finding that it works better in conjunction than in isolation.
Yeah. So you go in. If you're in a place, your cholesterol is high, your triglycerides are high. There's a lot of things to look at other than a statin drug. You could be looking at blood sugar. You could be looking at the insulin resistance that Dr. Gates was talking about. You can look at your thyroid. And if you've been able to follow this, and I hope you have, and I'd like comments back on this as to comments on the presentation, because sometimes we get a little technical. But if you're following all this stuff, you'll see how everything I just got done saying is so interrelated, just based on what we're talking about today. We're talking about the thyroid. You might look up another one of our talks on fibromyalgia and say, well, it sounds like their thyroid. It sounds like their thyroid talk. Well, it is, but certain areas like stress, for example, might be more emphasized in the fibromyalgia patient relative to her brain. But again, we keep looking at the same mechanisms over and over and over again for autoimmune problems, for fibromyalgia, for peripheral neuropathy, for all these things I keep mentioning. So PCOS, we talked about that already.
Right, I'm going to go into that a little bit more.
And it is important to go into it in a little bit more detail than what was done, than where we went before. Polycystic ovarian syndrome, multiple cysts on your ovaries syndrome.
And it's diagnosed as having that, as well as high testosterone. And if your
doctor sees that and kind of blows it by, not good, because you're about to find out why.
Exactly. So we've had OBGYNs say, well, unless they're 300 pounds and have a beard, I don't think the PCOS is significant. So just going back, PCOS is diagnosed as having cysts on your ovaries, having too much testosterone, which can manifest as having facial hair growth, and abnormal menstrual cycle lengths, 14 days, 46 days, 30 days. You have to have 2 out of those 3 to meet the criteria.
Why did they get the too much testosterone?
They get too much testosterone largely because they're insulin resistant.
Oh, here's that connection again.
They may have metabolic syndrome. And it can be a genetic issue too from the adrenal glands, but lots of times the insulin resistance will either cause our adrenal glands, which are our stress glands, the fight-flight glands in the body, to start making testosterone, or the insulin resistance will start causing the ovaries to start making testosterone. And the travesty of PCOS patients is that so often they will really adhere to dietary and exercise regimens and they can't lose weight. And the reason why is that there are very specific reasons in their physiology relative to insulin why that is not allowed to happen. However, there are studies now showing that 43% of PCOS patients have Hashimotos Thyroiditis. It is now overwhelming that a significant percentage of PCOS patients have subclinical hypothyroidism. So you can see from this, we started out with just hypothyroidism. We have this huge intermingled web of physiologic dysfunction that encompasses everything from autoimmune problems, the reasons behind the immune system killing the thyroid, to your thyroid conversion not happening appropriately in your gut and your liver, which may be tied to the immune problems, which then dovetails into insulin issues, and the thyroid problem causes the insulin issues to get worse. And now we're talking about a menstrual issue, all resulting in you to be depressed, obese, have miscarriages, and cardiovascular disease, and not know why.
Yeah, we have a cool little chart here. It's not actually little, and we have all of this on a chart. There's arrows going everywhere, and people walk in, and they said, well, but I was just here for a thyroid problem. I was hoping maybe there was a different medication or another, maybe a herb, or maybe iodine.
We didn't even talk about iodine.
Come on, we got to talk about iodine.
Okay, so all you alternative.
Well, the reason I picked it up is because when you hear me chime in, it's because I want to make sure we cover the areas of interest that I hear every day in the consultations that I do. The iodine deal is like divisive. I mean, it can get emotional. It's like, no, my other alternative practitioner said I have to take tyrosine and iodine. So I think it's important to kind of put that in there a little bit and kind of take a step back and put that in there.
So going back to the thyroid gland makes inactive thyroid hormone called T4 based on converting iodine and hydrogen peroxide into a molecule called T4. And so a lot of people in the alternative community said, well, if somebody has hypothyroidism, let's give them iodine. Will that allow them to make more thyroid hormone?
Right.
The problem appears to be that because so many hypothyroid patients in today's society, we're not talking 1960 in Kansas when there was an iodine deficiency. In today's society where there isn't an iodine deficiency, when people take iodine, it actually initiates the immune response to get overactive when it's already overreactive. So it heightens the immune response to the thyroid because the immune system is killing the enzyme specifically in the thyroid that converts iodine and hydrogen peroxide into active thyroid hormone. Right. And we've attached several articles to today's broadcast about people eating kelp and developing thyroiditis, people taking iodine and getting dramatically worse, taking iodoral and getting dramatically worse. And so it's something you really need to be vigilant of. That's really a problem that was present 50 years ago and is not present today in this country by most standards. Yeah,
it's really interesting. It was so obvious the first time I read it. It was like, okay, you have this iodine. So T4 is a protein that has 4 iodines.
Mm-hmm.
Put next to it, and then you have an enzyme that allows that reaction to take place. Well, the protein and the enzyme are the 2 things that are attacked by the immune system.
Exactly.
I'm just trying to make it a little simpler for we kind of blew by this for some folks. And so if you're putting more iodine in there, you're getting more of this protein, you're getting more of these enzymes having to come in, and that's what the immune system attacks to create Hashimoto's thyroiditis. And so, and it's still, no, I stop people coming in here. I mean, it's like you have Hashimoto's, like you want to pour gasoline on a fire, take iodine. You want to really get sick, take iodine. And so I hope, that's an important point. I want a lot of you to know that. If you're asking about thyroid, if you're interested in thyroid, you need to know that. So, I think that pretty much covers it.
I think we've covered it.
I think that pretty much covers it. That was kind of like a rapid fire type of thing, but we wanted to more bring an overview of hypothyroidism to you so you can make decisions on your own. It's like, whoa, maybe this isn't working for me because of that, or because of this, or because of that. And I can assure you, if you have a thyroid problem, let's say you have a confirmed thyroid problem, but your numbers are off and you're trying to diagnose it. This is more commonly what goes on, and your numbers are off, and your doctors are trying to dose and it's driving you nuts, and it's not working. It's because of all this. How much of hypothyroidism is this, according to the literature? Is all of this put together? In other words, patients are still under the impression that my thyroid is slow, it's not working, and I'm going to the doctor to take a medication that's going to make it work. Right. That is classical hypothyroidism. If you have that, here's how you know. My question to Dr. Gates is, how many people actually have that? And if you have that, you take the medication and you feel better, like immediately,
better.
like within days, within 72 hours, you're like happy guy. You're like, the weight's starting to come off, you're happy, your hair hasn't grown back yet, but you'll know you have it. If you're going off in any other direction, this is why, okay? And what I was trying to articulate, and I didn't frame that question very well, is how many people, based on the literature, okay, because I know Dr. Gates likes to be very careful of being accurate. Based on the literature, how many people actually have hypothyroidism? How many could we project potentially actually have hypothyroidism?
I have a thyroid disorder?
Yeah, they have.
Wait, like pure hypothyroidism?
Pure hypothyroidism. Who have a thyroid, of all the people who have thyroid problems, how many actually have pure hypothyroidism?
I don't know that I can specifically answer that question because we don't really know. I think it's very, very small, okay? Because there's this whole new entity called seronegative Hashimoto's, which is where the immune system is attacking the thyroid and there aren't any immune cells. So just, you know, we got a thing from LabCorp and they said 95%.
That's what was going.
Because LabCorp has all the laboratory information. So they have a huge data bank. So they can see, okay, this many people have hypothyroidism, this many people have elevated antibodies to the thyroid. So they figured out that 95%
That's right.
of hypothyroid patients have Hashimotos Thyroiditis. However, there's this new entity now called seronegative Hashimoto's where you don't even have to have the antibodies. So that potentially could account for another 3%. There are a few variants of hypothyroid, like Riedel's hypothyroidism, postpartum hypothyroiditis. So we'll leave a little buffer, but just know that Hashimoto's is encompassing most of you out there.
Yeah, don't sit out there thinking that you're the only one who's not responding to your thyroid medication.
Well, that's acknowledged in the literature.
Yeah.
I cited that article, it's up on our website, where they said a lot of people take T4, levothyroxine, Synthroid, and they may feel a little better, but they don't feel significantly different in terms of weight and a number of other issues. And that is why the Mayo Clinic is indecisive as to whether to treat you or not.
Exactly.
And that's why they're saying, we need a bigger study, because basically they're saying, well, we're not really sure even if we give you T4 that you feel a lot better. And the reason why is for all these 20 reasons Dr. Rutherford and I just laid out as the underlying aspects of why you don't feel better. And in addressing these underlying aspects is why we have observed some pretty neat changes in an integrated fashion for patients who never had felt well.
Yeah. And we could go on for another 24 hours with this, and we're not going to do that. But truly, we could go on for another 24 hours with this if we teased out every one of these subjects and really went through all of the mechanisms and all the variations. It's a very, very complex subject. We unfortunately found that. Fortunately and unfortunately. Unfortunately, because it takes time to walk a patient through the algorithm that we have designed for this paradigm to figure out which exact areas are pertinent to that particular person's thyroid picture. And so it's a little unfortunate that it takes 2 or 3 or 4 or 5 or 6 months to walk through something like this. But it is fortunate that this paradigm is emerged. This paradigm is being confirmed in the literature by the week, it seems like, or certainly by the month. More and more data is confirming the types of things that we're seeing. So we feel on a pretty good solid basis sharing this data with you with a pretty good amount of certainty. We feel that because this is what we see in our clinic, and the results are pretty successful. I was going to say pretty consistently successful, and so we feel pretty confident sharing this with you. So I think we have covered a pretty general but comprehensive the parameters of what actually causes thyroid problems. We didn't really get in totally into how they're treated. They're treated by treating all the different things that we talked about, and I can get into, that's all over our website. If you look at powerhealth.com, if you want to know about PCOS, there's several things there on that. If you want to know about insulin resistance, there's several things there on that. Whatever you want to know about, everything we have talked about here and alluded to is expanded upon in different specific areas of the website. So this is the first time that we approached this subject in this manner in a public forum, and any feedback that you have for us, we would certainly be open to hearing and appreciate hearing, whether we agree with you or not. And but any questions that you might have specifically, please feel free to, man, what is wrong with my mouth today? Please feel free to contact us at powerhealthtalk.com or anything else.
Nope, I think we covered.
Okay, and Dr. Gates will do his best to get back to you sometime if you happen to take advantage of that offer. So thanks for watching.
Thank you for watching.
Yeah.
We'll talk to you soon.
Okay.